I'm going to be your nurse today.
Hi, good afternoon.
I'm just washing my hands for your safety.
Okay.
Can you tell me your name and date of birth?
John Doe, March 1st, 1970.
Okay. And can you tell me where you are?
I'm in the doctor's office.
Okay. And do you know about what time of day it is?
It's around 5:45 p.m.
Great. So notice that the patient is alert and oriented to person, place, and time, or you can say A&O times 3. I'm also doing a general survey, taking note of the patient's appearance, his body structure, his mobility, and then also his behavior and the interactions that we have together. So I am here to do a head-to-toe assessment on you. And do you have any questions before we get started?
No.
All right, I'm going to start out by taking your vital signs. If I can have your left hand, this just goes on your finger and it measures your heart rate and your oxygen saturation. I'm also going to take your temperature, 97.5. Heart rate is 73 beats per minute, and pulse ox is 96% on room air. Gonna get your blood pressure next. I could just have you extend your arm for me. Make sure that your artery index marker is over the patient's artery. You can either find the artery by listening with your stethoscope or feeling the pulse with your finger. You also want to make sure that the cuff size is appropriate for the patient and fits snugly. Placing the diaphragm of your stethoscope on the patient's artery, press firmly. Have the patient relax their arm, making sure that their feet are flat on the floor, uncrossed, and ask the patient not to talk while you're taking the blood pressure. Inflate the cuff 30 millimeters of mercury over the patient's typical baseline blood pressure. Once there, slowly start to deflate the cuff, listening for the first beat of the blood pressure. That is the systolic number, and the last beat that you hear is the diastolic. And then release the cuff all the way. Okay. So we have 125 over 78. And are you having any pain today?
No.
Okay, I'll have you get up onto the exam table for me. And I'm going to start out by inspecting the patient's head, face, and neck, looking to see that the eyebrows are symmetrical, that the frown or smile lines are symmetrical, and also noting any lesions on the face. I noticed that you have a mole here. Have you always had that?
Yes.
Okay, have you noticed any changes in it?
No.
All right, great. This would also be the time to ask the patient if they're having any dizziness, any headaches, any bumps or swelling that they notice, or if they have a history of head injuries.
I do not.
Okay, great. I'm going to start by palpating the carotid arteries. There's one on each side. We do them individually, not at the same time. Pads of 2 fingers. Okay, and then the other side. Now I'm going to assess the temporal arteries. Please note that these are not at the temples, they're in front of each ear. Okay. Now I'm going to press on the maxillary and frontal sinuses, asking the patient if they have any tenderness. The frontal sinuses are in between the eyebrows. Any tenderness here?
No.
Maxillary on each side of the nose. Any tenderness here?
No.
Okay. Next, I'm going to assess for the thyroid. We do this from behind the patient. Can you tilt your head down and slightly to the right for me? You're gonna feel me touch here. Get your fingers on each side of the thyroid, ask the patient to swallow. Okay, great. And then just look straight ahead. I'm noting that the trachea is midline. Next, I'm going to assess for the trigeminal nerve, asking the patient to clench their jaw. Can you clench your jaw? Great. Then I'm going to assess for cranial nerve 7, asking the patient to puff out your cheeks, raise your eyebrows, smile, and frown. Okay, great. And then can you close your eyes really tight for me? Excellent. Now I'm going to assess the hypoglossal, asking the patient to say light, tight, dynamite.
Light, tight, dynamite.
And then can you stick out your tongue straight ahead for me? Great. Next, I'm going to palpate all of the lymphs or lymph nodes, starting in the back, which is the occipital. We do this at the same time, noting any differences from one side to the other. Then we're going to move to behind the ear, which is called the postauricular. In front of the ear, preauricular. Down where the jaw meets, which is the parotid. Moving down to the tonsillar, submandibular, submental. Then we're going to do anterior cervical, which is on the front here. Posterior cervical on the back side. And then supraclavicular means above the clavicle, both sides. Okay, I do not feel any nodes. If I did, we would want to make mention of that and the characteristics. Next, I'm going to inspect and palpate the skin, noting any lesions. So I do notice that you have some moles here as well as some freckles. Have you noticed any changes in your skin?
No.
Okay. All right. And you want to note the color, which is appropriate for race, and his skin does feel warm and dry. Next, I'm going to assess the skin turgor by taking a little bit of skin on the top of the patient's hand and pulling it up, letting it go. We're looking to make sure that that returns within 3 seconds. We do both sides. Great. Now we're going to assess the capillary refill. Does not matter which finger you choose, but you do want to depress the nail until it turns white and then watch for it to turn back to pink. We're looking for that to happen in less than 3 seconds, testing both sides. We also do this in the toes. When we assess for perfusion, we want to make sure that we're getting that to the upper and lower extremities. Okay, now I'm going to inspect the external structures of the eyes, just kind of taking a look, making sure that they're symmetrical, looking to see if there's any edema, any redness, any discharge. Are you having any issues with your eyes?
No.
Okay, can I ask you to take your glasses off for me? Okay. Now I am going to assess cranial nerve 3, 4, and 6 by asking the patient to follow my pen light in the 6 cardinal fields of gaze. Make sure that you go slow enough that you can actually see what the patient's eye movement is doing. We're looking for any extra movements, such as like a little ticking, which is called nystagmus. So if you can follow my pen light with your eyes only, not with your head. Excellent. The next thing that I'm going to assess for is the light reflex. So this is called the twinkle test. I'm going to shine my light from the side, and what I'm looking for is to see a little twinkle in the colored part or the iris of your eye. You can just look straight ahead at me. Present and present, so bilaterally. Okay, the next thing that I'm going to do is the confrontation test. I'm going to put my hand behind you, and what I'd like for you to do is let me know when you see my fingers appear in your peripheral vision. So you'll look straight ahead at me, and then just let me know when you see my fingers appear.
Now.
Okay?
Now.
Great. And we are assessing cranial nerve 2 with that confrontation test. Next, we want to assess Perla. So are the pupils equal and round? We look at the pupils. Yes, they are equal and they are round. Now we want to know if they react to light. We do this by shining our pen light into each eye. You put your hand here up against the nose. I'm going to shine my light into your eye. Just look straight ahead. That pupil does constrict, and so does the other one. I'm going to do the other side. That pupil constricts, and so does the other. Now we want to test for accommodation. Ask the patient to look at the tip of your pen light and then follow it as you bring it toward their nose. You're looking to see that the pupils constrict and that the eyes move in toward the nose, which they do. Okay. Let's see. Now I'm going to inspect the external structures of the ear. Again, making sure that they're symmetrical on each side, looking at the color, noting if there's any redness, any swelling, any drainage. Then I want to palpate. Are you having any pain?
No.
The tragus is movable. Any tenderness here?
No.
On this side?
No.
Okay, so no issues with the ear on the outside. Next thing that I'm going to do is the whisper test, and we're checking cranial nerve 8 with this. I'm going to ask you to close this ear off by pressing in the tragus. I'm going to whisper 2 words behind you, and can you repeat those for me?
Apple, banana.
Okay, and then occlude this side.
One, 7.
Excellent. Now I'm grabbing my otoscope. And I'm going to pull up and back, looking inside the ear for the eardrum. I am not seeing any swelling or redness. The eardrum is intact and pearly gray. Now I'm coming to the other side, switching hands, pulling up and back on the ear. No redness or drainage noted. The tympanic membrane is intact and pearly gray. Now I'm going to inspect the external structures of the nose. And if you can just look up for me. Okay. No redness, no swelling, no drainage, and it appears that the septum is midline. Can you occlude one side and breathe in? And then do the other. So the nostrils are both patent. Okay, next I'm going to have you open your mouth for me. And I am just checking that the oral mucosa is pink and moist. The teeth are in good condition. The tongue looks healthy, pink and moist. And then can you stick out your tongue and say ah?
Ah.
Okay, excellent. So I was checking cranial nerve 9 and 10 when I asked the patient to say ah. And now we are going to do the thorax assessment. And I'll begin by asking the patient to rest their arm across their abdomen and just breathe regularly for me. I'm going to count your respirations. Okay, so I counted for a full 30 seconds, and then I'll multiply that number times 2. I got 9 breaths in a 30-second period. We multiply that times 2 for 18 breaths per minute. Okay, thank you. And at this time, I'm going to ask you to take your shirt off for me so that I can assess your thorax. And if you can swing your legs to the side for me. Great. I'm going to start out by palpating the posterior chest for any tenderness or masses in the 4 areas. So any pain here?
No.
Here?
No.
Here?
No.
Here?
No.
Okay, so we've palpated in all 4 levels for any chest tenderness and masses. Now I'm going to palpate for tactile fremitus, asking the patient to say the word 99 every time they feel my hand touch their skin. What we're assessing for is the vibration made from their voice, and we want to make sure that it feels equal on both sides in all 4 levels. Okay, so when you feel me touch your skin, say 99.
99. 99. 99. 99.
Okay, thank you. Now I'm going to percuss the posterior chest for consolidation in all 4 levels, remembering that percussion takes place by only pressing the middle finger of one hand on the patient's skin and then quickly tapping with your other middle finger on top of the middle finger that's on the patient's skin. We do this in 4 areas. Be sure that you are avoiding the scapula because our percussion sounds will change if we're over bone and we're wanting to percuss for the lungs. Okay. Working side to side. Down the scapula. Okay, great. Next, I'm going to percuss for CVA tenderness. We do this by placing a flat palm over the patient's kidney, striking it with our fist, and asking if they feel any pain or tenderness. Remember, the kidneys are not low down, they're just underneath the rib cage here. So flat palm, when you feel me press against my hand, let me know if you feel any pain or tenderness.
No. No.
Okay, no CVA tenderness noted. The next thing that I'm going to do is auscultate breath sounds at all 6 levels of the posterior chest. And when I do this, I want to verbalize whether or not I'm hearing any crackles, rhonchi, or wheezes, and if the inspiratory effort is normal or abnormal. So is it regular or is it labored? Okay, you'll feel my stethoscope touch you. And when I touch you, I need for you to take a deep breath in through your mouth and exhale through your mouth. Okay, starting up high with the diaphragm. Working side to side. Moving down, avoiding the scapula. It's important to make sure that when you're listening that you allow the patient to fully breathe in and fully exhale so that you're listening for a full breath in each location. All right, now I am going to auscultate the carotid arteries on each side, listening for bruits. Again, remembering that bruits are a swishing sound. And the other side. Okay, and I'll have you face back front for me. And now I'm going to auscultate the anterior breath sounds at 4 levels. again with the diaphragm. Level 1. Level 2. Level 3. And then level 4 is going to be on the side. Okay, no crackles, rhonchi or wheezes noted, and the inspiratory effort is normal. Okay, the next thing that I'm going to do is auscultate heart sounds, remembering that we're listening for S1 and S2 sounds in all 4 of the locations. Ask the patient to breathe normally. With the diaphragm first, we're listening for S1 and S2, starting in the aortic. We hear S2, the loudest here, remembering that the heart is upside down, so the base is at the top of the chest and the apex is at the bottom. Lub-dub, lub-dub, lub-dub. So I'm hearing dub louder because that's S2, so I'm hearing lub-dub, lub-dub, lub-dub. Moving over to pulmonic. Again, S2 is louder here. Lub-dub, lub-dub. Moving down to the tricuspid. Now S1 is louder here, so I'm hearing lub-dub, lub-dub. Moving over to the mitral, 5th intercostal space, mid-clavicular line. It's going to be almost underneath the patient's nipple. Again, S1 is heard loudest here, so I'm hearing lub-dub, lub-dub, lub-dub. Once we've listened with our diaphragm, now we switch our stethoscope over to the bell, and we're listening for S3 and S4, and we're also listening for any murmurs, so those swishing sounds. Aortic. No sounds. Pulmonic. No sounds. Tricuspid. Mitral. And remember, you're not always going to hear S3 and S4, and if the patient doesn't have a murmur, you won't hear that either. So that's great. Okay, now I'm going to help you lie down so that I can assess your abdomen. Just lay back. I'll slowly recline you. Okay. So I noticed when I laid you down that you had a bulge here over your umbilicus. Have you had any issues with hernias or been told that you have a hernia?
I've had issues with hernias in the past.
Okay, so I'm actually going to ask you to try to sit yourself up. Students, please notice the bulging that occurs here. Okay, that's good. I don't want you to hurt yourself. Okay, all right. So now we're inspecting for contour. We're inspecting for bulges like you just saw there. Normally you would do this from the side of the bed, but I'm doing it here so that you have a view of the patient, but typically just know that you would be standing on the side for this, not at the patient's feet. Okay, now I'm looking for any pulsations in the aorta, which is this part right here. We do not want to see any pulsations. Sometimes on a thin, real thin person you may, but you do want to visualize that and notice if you see any pulsations like heartbeats in that aortic area. Okay, next we're going to auscultate the abdomen for bowel sounds in all 4 quadrants. It's normal to have bowel sounds anywhere from 5 to 34 per minute, and we'll hear those in all quadrants. Okay, so I always start at the lower right, and then I work my way up, over, and down in a clockwise fashion. If for some reason you do not hear 5 sounds in that 1 minute, you would want to listen for a full 5 minutes before documenting that bowel sounds were hypo. Okay, so I'm just going to listen here. With the diaphragm. Remember to check it because you just got done listening to heart sounds. It may still be on the bell, so make sure that it's switched back over to the diaphragm. Should hear some good gurgling there. And then we move up into the next quadrant. Close to dinner time. Somebody's gurgling. Next quadrant. And then the fourth quadrant. Okay, now we'll switch over to our bell, and we're gonna listen to the aorta. We're gonna also listen to the iliac and the renal arteries. So we're gonna put this right over the aorta, listening for any bruits, so any swishing sounds, and I don't hear any. And then we're gonna go to the renal arteries, which is just slightly lower and to the left, or to the patient's right, but to our left. And then the opposite side of that. And then the iliac arteries are on each side of the umbilicus. No swishing noted. Now I'm going to perform light palpation, and we do palpation with 3 fingers, the pads of each, so we're not digging deep. We're resting the pads of our fingers on the patient's skin, and we're just doing light palpation where we go slightly into the skin in a circular motion, and we do that in 3 areas per quadrant, asking the patient if they have any pain or tenderness when we do that. Starting in the lower right quadrant. Any pain or tenderness when I press here?
No.
Okay, so we move up to the next quadrant. Any pain or tenderness here?
No.
Any pain or tenderness here?
No.
And pain or tenderness here?
No.
Okay, and now we help the patient sit up, grabbing their hand and raising the bed. Okay, all right, you can put your shirt back on. We're almost done. All right, now I'm going to inspect and palpate the joints. This would also be the time to ask the patient if they're having any issues with any of their joints. So starting with the wrists, can you move those around? Any pain there?
No.
How about with your elbows?
No.
Shoulders? Okay, able to move
Nope.
there. Knees?
Mm-hmm.
Okay, ankles? Excellent. No pain, no issues.
Nope.
Okay. Next, I'm going to assess your strength by having you squeeze my fingers. Okay. Then, if you put your arms like this, I'm going to have you pull me in. Okay, and then push me away. Same thing with your legs. Pull me in and push me away. Good. And then I'm going to press on your shoulders again, and I want you to shrug them against resistance. When the patient shrugs against resistance like that, we are checking cranial nerve 11. Okay, great. And then I'm going to palpate the pulses, starting with the radial. So on each side of the inner thumb here, up on the hand, up on the arm. Okay. All right, and then I'm going to go to the dorsalis pedis. I'm going to raise your leg here. The dorsalis pedis is on the top of the foot, up from the big toe, about a third of the way of the top here. Be careful not to press too hard or you won't feel it. So this is the dorsalis pedis. And then the posterior tibial is on the inside of the ankle, just behind the ankle bone. Okay, great. And while I have the patient's leg here, I'm going to press against the shin, checking for any edema, and I don't have any edema that I see here. We check the pulses on the other side, again, in line with the big toe, about a third of the way up the foot. Okay, posterior tibial, behind the ankle bone. Okay, and then pressing against the shin for any edema. Okay. I'm gonna check deep tendon reflexes. So we do this with a reflex hammer. Having the patient just dangle their legs, I say let them feel heavy, like they're just kind of swinging. And then the tendon that we're gonna do is right underneath the patella. So right here on the front of the knee, underneath the bottom of the patella. So just kind of let your leg dangle for me. Okay, so there's the reflexes. We do grade these, and we can call this hypertonic if his leg would like almost hit me in the face. Those would be hypertonic reflexes. If I only saw a very little movement of the leg, we would call that hypotonic. Okay, so I'm gonna, just kind of let it hang. Okay, great. So that is the patellar deep tendon reflex, and now we're gonna check the bicep deep tendon reflex. Just ask the patient to rest their hand on their leg. You're gonna find, actually you can ask them to kind of make a muscle, and then you'll feel that tendon in the brachio area of their arm. You're gonna grab that with your thumb, and then ask the patient to rest their arm down, and then you're gonna hit your thumb with the reflex hammer, and as you saw, his arm jumped when I did that. What we do to one side, we do to the other. So go ahead and make like a muscle, find that tendon, grab it with your thumb, ask them to rest their hand down, using that reflex hammer, hit your own thumb. Okay, great. And next I'm gonna assess cerebellar, or the cerebellar test through rapid movement. Ask the patient to put their hands on their legs and then flip over, so supination, pronation of the hands, and then ask them to do that as fast as they can, flipping back and forth. Okay, great. And then the next test that we have them do is touching their thumb to each finger and back as fast as they can. Wonderful. All right, now I'm gonna ask you to do the heel to toe walk. If you step down, I would like for you to walk to that corner for me, doing heel to toe. Okay, and then back. And then I'll have you stop there. Feet together, hands by your side. I'm gonna watch you for 30 minutes, just looking for any swaying. I'm sorry, 30 seconds, not 30 minutes. Okay, and so while you want to be mindful of the clock, you also want to be watching your patient for any swaying, because when the 30 seconds is up, we're going to ask the patient to close their eyes, and we're going to monitor them for another 30 seconds, noting any differences in the swaying. And I'll be here next to you in case you get dizzy. Okay, close your eyes for me. Okay, notice he is having a little bit more swaying with his eyes closed. Okay, and this is the Romberg test. Okay, great. That's it. Do you have any questions for me?
No, I think I'm good.
Thank you.